well, psychiatry doesn't have any biomarkers. It's like, that's what psychiatry is. It's problems that don't have biomarkers.
Dr. Beach, thank you for being here today. So you're my fourth guest, which is, again, very grateful for. First psychiatrist / psychodynamic psychotherapist on the What the Fuck is Life podcast. So to have an MD is an honor in that way. And you come with your own perspective. Today, although we are loosely framing this, we certainly have a consensus as to what we want to speak to, which is this demarcation between not just different forms or modalities of psychotherapy, but how pharmacotherapy is either introduced to that or supplementary to that, or even sometimes, as we just spoke to, thought about tiffing in the field for you, and how psychopharmacology plays a role in developmental psychological health or just plain healing. So with all that said, very excited to have you. Thank you again. And if you could introduce what it is you feel most, again, compelled to speak to in this vein.
Well, sure. I appreciate the opportunity to talk with you, Max.
Yeah, no, I'm very famous at this point.
Excited about your endeavor, so glad to be a part of it.
Thank you. I appreciate it, Doug.
Yeah, there's many directions. I went to medical school with the idea of becoming a family doctor, but realized that I came from a small town, and the idyllic image of the family doctor was someone that you could talk to about your problems. I, didn't have any exposure to psychiatry at all growing up, or really had no familiarity with it. But during medical school, realized that the material itself was interesting, and I think I've been really fortunate to. I feel like I kind of caught the tail end of what I would consider to be really good broad-based training as a psychiatrist, where it was implicit that you were a therapist in addition to being a physician, and was around a lot of really good and influential mentors during training. This is in the early 90s, where, the end of the 80s, DSM-3 in 1980, second wave of antidepressant medications in the late 80s, and then second wave of antipsychotic drugs. This bifurcation existed in psychiatry all along, the dualism between the biomedical model and a psychosocial model, the medication prescribers versus the analysts, to simplify it. But I was fortunate to be around people who could integrate all of those. And from the beginning, it was just a given that those different modalities would be integrated or would be a part of what any particular psychiatrist could offer their patients. What I realized in practice, though, was that increasingly, this varies greatly, I think, by region and time, but increasingly, um, psychiatrists were, in a sense, relegated, but then also flocked to the role of prescriber. And I think, as in much of healthcare, it's driven by primarily the payers. In other words, what is there a market for, and what physicians and other healthcare providers do is driven by the third parties that pay the bills, primarily insurance companies. So that shaped practice quite a bit, and it was just in overdrive in the 90s. Really aggressive managed care. I interviewed for a job in residency. I wasn't serious about taking it, but they were hiring the psychiatrists and scheduling 5 patients per hour, and the assumption was one of them wouldn't show, so it was only 4 patients per hour. So, and this was just,
Easy.
yeah, it's just so out of the realm of potential practice options for myself. But it has become increasingly the case that psychiatrists are sort of relegated into that prescribing role. But those of us who identify still primarily as psychotherapists, who happen to be physicians who may also prescribe medication, that's become a rarer and rarer version of psychiatry with time. And that continues to be the case.
Yeah, it seems obviously part of the reason I wanted to speak with you today is not only your experience in that and expertise, of course, but that this unfortunate reality that integration seems to be old hat, that maybe, as you said, this bifurcation or trifurcation between psychopharmacologists, psychiatrists, psychotherapists has gotten louder, or the walls have been built up. And the cost, of course, is to not only the training for the clinician or physician, but the cost is to the patient, themselves, where the quality of the care has gone down. As I've spoken with other people in other episodes, that the dilution is unending at this point. Between there's more access to care, the democratization is a wonderful thing, you could argue, but the devil in the details that nobody speaks to, or maybe some people speak to, is that the quality's really gone down. And so most people in my experience, be it current patients, past patients, my own training experience, their relationship to their psychiatrist, which is most of the time, or NP, I should say, is super common too, psychiatric nurse practitioner in particular, is just med management. And they meet a series of criteria to be prescribed a drug. Often, like you said, these second or third gen SSRIs, SNRIs, atypicals, rarely benzodiazepines because of all sorts of controlled substance stuff. And that's it. And then they go back to their therapist, and the therapist doesn't even have a relationship, let alone any form of psychopharmacological training to even integrate that information into what they're doing with the patient, or as to why the patient is on that particular medication. And that's, to me, as you recognize, is a huge problem. Or to speak very plainly, and jokes aside, but just the stereotype of the young woman getting her Lexapro from the OBGYN or the GYN. I can't tell you how many times I've heard that, or the primary care physician. And they get their Prozac, Lexapro, Celexa, Effexor, what have you, as they're super common. And these people have no training in terms of psychology or psychopharmacology.
Yeah. Well, I think that the majority of pharmacological treatments, especially the high majority of antidepressants, the number is usually 85-ish%, are not prescribed by psychiatrists. And I think
I have to interrupt you. Can you repeat that? I don't think people realize that, genuinely, Doug.
yeah,
Is it
yeah,
really that high?
yeah, and it has been all along. It's not just with the newer wave of medicines.
You
Yeah,
said
so it's around around
85%.
around 85%. That number varies, of course, or not prescribed. And I think the number for benzodiazepines is over 90, 92%. And I'm always eager to defend the primary care doctors who do many of whom do a fine job.
Sure.
There are several, internists and OBs in town and pediatricians who do a good job of assessing and prescribing. And there's a shortage of psychiatrists, and they do what they can. But I think you mentioned the collaborative treatment where the psychiatrist or psych NP or PCP is prescribing, and the psychotherapy is being done by another professional. And I think that collaborative arrangement can work if the two people communicate. And what it often is, what I've seen is it can be a setup for avoidance, where the patient sees their doctor, whoever the prescribing clinician is, and issues are mentioned, and they're focused on medication, and the prescribing clinician says, you really should talk to your therapist about those things. And then the patient's seeing their therapist, and their symptoms are great. They're more depressed, they're more anxious, they're not doing well. And the therapist says, when was the last time you talked to your doctor? Maybe you need a medication adjustment. So by configuration, by no one's intent, some issues sometimes can get avoided because of the way the helpers are arranged if they're not collaborating with each other and communicating. So ideally, when there is split treatment, which I know is the common model, there be some kind of communication between the clinicians so that if there is the potential for avoidance or resistance can be addressed also.
Yeah, it's again, it's wild, it's uncanny, it's almost untenable, if I want to get controversial already, because in my experience as of course, my doctorate is I'm not an MD, I'm an analyst, but my doctorate's in my dissertation is in psychoanalysis and sort of phenomenology, ontology, but it was in legally a doctorate in clinical social work. And all this is to say, I have to proactively work collaboratively with a prescribing physician, and I have to tolerate sometimes, in my experience, where they are more keen, as you were saying, on the biological model. I perceive it or experience it as sometimes as reductive. They experience my poetic Kool-Aid drinking indoctrination of being an analyst as wacky, anachronistic, taboo, and maybe straight up nuts. And so I do most of the time find common ground, thankfully, but it is that elephant metaphor of, you have all the blind men or women touching the elephant, and they're saying, no, that's the nose, or, that's the tail. And they don't understand that it's a whole enterprise or a whole organism. And the person who suffers, of course, is the patient. And I guess maybe one point to parlay into bringing your response into the fold is that as a psychotherapist, I feel, I can't say we, but we tend to feel more kowtow or defer in saying you want the MD to be the one prescribing and in charge in that domain. And legally, right, there's a certain amount of anxiety. So I certainly have patients in my experience who speak to me about their relationship to a medication, the phenomenological experience, although that's a bit redundant, their side effects, adjustment effects, et cetera, et cetera. And sometimes I have to tread lightly, right? Because I'm not legally allowed to speak to it. At the same time, I can speak to some things given my electives or extra, postdoc training. But you need to work hand in hand with the one who's trained, most robustly in this
Yeah,
domain.
ideally.
And so I guess my question then for you is both for those psychiatrists who don't receive any form of psychological training, and then for those psychologists, social workers, mental health professionals, analysts who lack any training in psychopharmacology. What's your experience been with that? Is that something you still teach? Is that something you try to proliferate or celebrate? Or what's that like today? Is it work?
Well, I think as have been topics on your other discussions so far, most people are aware that there's many different societal changes that have come about just with the proliferation of technology into healthcare, telehealth, the emergence of social media platforms that promote various kinds of wellness initiatives, and increasingly people can seek and obtain pharmacologic treatments um, through online providers, and we could just expect that to continue to proliferate. So I think the fragmentation of a care system that was already not well integrated, I think we could just expect that fragmentation to continue. So what's a patient to do? I think it's ideal if you can get a referral from a trusted source. I still go back to the old model of the primary care physician refers to the specialist. And so I think it varies person by person. Very well trained, very interested, curious individuals in counseling and in the counseling field, and the social work field, and the psychology field who know quite a bit about the pharmacologic therapies and their limitations and their indications. And there are psychiatrists who are also, again, they're rarer and rarer, but who identify as therapists or who are very fluent in the different kinds of therapy and form collaborative relationships with individual providers. But it kind of cuts both ways. There are some non-physician mental health professionals that I would feel more comfortable referring a patient to than some psychiatrists, and no matter what the problem was. So, yeah, getting to know people in the community, having a conversation, a phone call, putting voices to names, and that has served well through the years. Just the idea of calling a doctor or calling a therapist sometimes will put them in shock that you wanted to talk to them, even if it was just for a few minutes. But just having that connection that's at least a little bit personalized, that's often a helpful backdrop to collaborate around.
Yeah, it's also, as you said, rare and rarer. I think of the way people source referrals nowadays, the way people make these connections, substantively or neurotically, or maybe both, the efforts both. And it's through Psych Today, it's through a listserv, it's through a group practice through Google, it's through a hospital referral sheet. And on the referral sheet, 10 of the physicians have passed. So I've seriously experienced this where at my own institute, the referral sheet, when I think I had to do one of my control cases, and there were people that were crossed off. This is morbid. This is gallows humor, but there were people crossed off because they had passed and they hadn't updated the sheet, because I don't even know if it was a digital file and it was just a copy that they made a copy and a copy. And the person, passed in 1987. And it was like,
Oh
it's,
yeah, I've seen that with the provider panels provided by the insurance
right,
networks
right.
too. That's happened over and over again. Where I used to tell the story of asking, I couldn't see someone, could, if you want to send me a list of providers from your insurance company, they'd fax it over at the time of fax. I, this is 2005 or so.
I wasn't even born yet. No, I'm just kidding.
So someone was, yes, so someone was on that list who had died in 1998. But the same thing happened about 8 or 9 years later. Same name. So the list had been obviously just compiled through some kind of algorithm on the internet. And but it'll say at the bottom of that list, we bear no responsibility for the accuracy of this list, and you have to check with the individual provider.
Nor of these people's deaths. They have to cover their ass.
Right, right. Yeah. So yeah, I can appreciate though, it's one of these many paradoxes though where the internet gives us so much access, yet there's more and more noise, less and less signal. So there's, on the one hand, it's a miracle that we can go online on supercomputer you hold in your pocket and access to all the world's information and providers. Yet at the same time, the reliability or the truth in that vast information is becoming harder and harder to find.
It really feels, yeah. You bring up another sort of parlay into a good point. The authenticity seems to transcend all of what we're speaking to, and has come up, as you mentioned, in other interviews I've
Mhm.
done. In that people really resonate with that. So if they back to picking up the phone or back to an email, which is plenty kosher, people can feel if there's earnestness or care or authenticity, genuineness, availability of heart, in as much as the attempt or actual connection. And so, be it a referral or an outreach, whatever, it does resonate in my experience. Part of the motivation to this episode or this podcast, this project you're speaking to, is to bring back a certain amount of humanity in these fields,
Mhm.
irrespective of modality or training, is to say that, well, how do we negotiate, tolerate, manage these lines in the sand vertically or horizontally or laterally or multidimensionally and help somebody. I mean, it's really, the horror stories are way too common. And like you said, I don't know what another word for rare is, but the how rare it is, how unique it is to find somebody who employs enough humility to continue to care, with skin in the game, as one of our colleagues would
Yeah,
say, Shedler,
yeah.
be it to do with providing medication and understanding the adjustment of that and the side effects, or be it providing a meaningful relationship in service of, reflective functioning and bringing awareness and conscious light where it hasn't been before. And I can't, it's just, it sometimes it's inspiring to see and have these conversations. And other times it can be quite disheartening to
Mhm.
feel how rare it's become.
Yeah. Well, it just makes it all the more valuable. I mean, there's a lot of discussion about, as you know, you've made allusion to it, but about mechanized therapy, manualized therapy, but AI delivered therapy is now a topic in mainstream health and online certainly. And that authenticity aspect. I have this fantasy that people may need therapy after having had AI therapy, like a post AI therapy stress
Right.
disorder.
Yeah.
That, but it's
It'll
for
be in the
this.
DSM-6. Yeah.
Yeah, right. But it's for this reason that you're alluding to. The caring part is kind of an essential core, and that's not in the manual. And I think it can be cultivated, but I don't think it can be really taught. That's at the essence of what we do as psychotherapists. Without that, all the degree and experience and trainings and manuals and techniques and tools really won't really won't help, because the person knows whether or not you care. They come to know that. They come to sense that, I think. And so that no matter what we're doing and how we're delivering it, that has to be there.
So given your arena of expertise as a psychiatrist, it is unique and useful, again, to ask you, how do you negotiate, like where we started today's conversation, this bifurcation or demarcation, which is to
Mhm.
say, how do you provide care and provide medication and provide therapy? Are you doing all those things? Are you at the same time? And what's that like?
Well, to me, it's really the only way to do it. It just wouldn't make sense to me to only ask about symptoms and prescribe medication. I'm more depressed. Okay, let's raise the dose of your medicine.
Sure.
I instantly want to know, well, what's going on? Why is that? I have a little anecdote for this. It's overly simplistic, but it illustrates, if someone walks in here with a headache, but they have a hat on that's too tight. And they say, I've been taking Tylenol for my headache. Do you think we could switch to ibuprofen? And I would say, well, we could consider switching to ibuprofen, but we really have to do something about that hat. And, you can do both. I mean, I think that's the dichotomy of the biomedical versus psychosocial that gets lost it seems as if we operate under the premise that it's one or the other when it's actually both,
Of
the either
course.
or versus both and it's funny, I was looking a case anecdote up in the introductory lectures, the Freud introductory lectures, and he actually made this very point. He's speaking to the psychiatrists in Vienna and about whether a delusion could have meaning or not and what the psychoanalyst had to offer. And he made this exact can't he's the language gets the English interpretation, but he says, can't it be both? Is there any reason we can't think it was inherited but also have meaning, or the particular kind of delusion this person developed? So, I use a version of, I think it would be called the biopsychosocial model, but I like the term pluralistic, that you think about a person's situation from all these different perspectives, from the physical factors, their underlying genetic predisposition, their physical health, their nutrition, their metabolic factors, and then you also think about their situation, their environment, the social aspect, the events and circumstances that they're facing. And then, the psychological aspect is, their personality, their developmental experiences, their maybe heritable temperament, their defenses, the unconscious mechanisms. All of those factors come together. I think I mentioned to you my pie graph model. That's what my current Substack post is about, the pie model. I don't know if it'll come out on your screen or not, but I'm going to hold it up just so you can see the pie graph.
Yeah, it's coming in. 3 viewers will be able to see this with us today.
Yeah,
But
yeah.
the physical, psychological, social, yeah.
Yeah, yeah. So you have factors from all three of those groups that come together. So in terms of how I approach, a person, I show them that, and I'd say, look, this isn't just do I have
Do I have to
depression.
trademark that, when I publish this episode?
I'll have my lawyer get in touch with you
Okay,
on it.
please, yeah.
So
Off the record, yeah.
but people find that very helpful, and so I've stuck with that. That's a useful way to think about, because people come in thinking, well, do I have a chemical imbalance, or is this just me? And so having just this simple way to organize all these factors is useful, kind of a distillation. And there's also the way you can think about help in a similar way, that medications are a physical treatment, just like there's TMS and ECT, metabolic interventions. I mean, there are physical treatments. Certain kinds of counseling might be thought of as social treatments, where it's oriented around a situation, like couples counseling to address a relationship, or vocational counseling if there's something in the occupational space. And then psychotherapy is a psychological treatment. So treatment can be thought about in those three big picture areas as well. So I think approaching it that way, and then it kind of depends on what that individual person needs. I guess there's this tension, and this comes up in these discussions about the different kinds of therapy. Anytime something is made into a system, it tends to get mechanized and depersonalized. So whether that's a manualized treatment or a managed care model of 6 sessions, or like you were talking with Nadim about the set number of sessions in a college counseling center, and anytime you mechanize something, it has the advantages of standardizing things, but it has the disadvantages of losing its authenticity and the individuality or the uniqueness of every particular person. And so that's why, to me, coming back to that model helps balance those. And the same thing happens in medication treatment, where, and I would say historically, if you look back, that's where psychiatry has often gone wrong, by sort of sending everyone for the thing that's available. Send everyone to the asylum, send everyone to the couch for psychoanalysis, send everybody for ECT. And what has come about in our era has been, send everyone for 15-minute SSRI med checks and 10 sessions of CBT, So there's always this tendency, anytime something grows and becomes systemic, to it becoming perfunctory and losing its flexibility to meet with the individual uniqueness of every person. And that's why I like the pie chart model. It helps identify what's unique about each individual.
Right. The integrative approach is obviously the most inclusive to individuality, to idiosyncrasies, to idiopathy. At the same time, it costs the most amount of time. It seems like that's the common denominator here, is that if it's managed care, if it's med care, managed medication care, if it's 6 sessions of whatever protocol or modality,
Mm-hmm.
or 12, there's no room. Like you said, there's no room. It's this Procrustean thing, right? Everyone's fit
Mm-hmm.
into this box, and that's all that's available. And that's, a fault of no physician, clinician, or patient themselves, but really of, like you said, the systems of, it's the university level, the hospital level, the health insurance company level, the government level, as discussed in other episodes. And sometimes fighting against that feels impossible, and you throw in the towel. And then other times you say, well, this person feels heard and understood, or in best approximation understood, depending on where you are in the treatment, for the first time. And they're saying, oh wait, this medication has is being considered in service of my psychological anatomy. Or wait a minute, there's my relationship to the medication has an effect on the efficacy of the medication, which is also a mind-blowing thing. People don't, we talk about placebo and nocebo, but nobody really substantively feels about placebo and nocebo until
Yeah.
it's in the room. And there's all these
Yeah.
things. I don't know if we have, hopefully we have time today, our next episode together, where
Mm-hmm.
we can speak to that science. It's really the iatrogenic stuff is not spoken to, or why this medication works for this person or not that one. As I've spoken to Christian many times about the swing, and maybe you could comment on this today, of phenomenological psychiatry, where people are really taking this both and integrative system, or the pluralistic approach, and saying, wait a minute, what Freud was saying and others. I like to think of what Oliver Sacks was saying, because he's so famous as a neurologist for saying that there was meaning in causality and in the information of the delusion or fantasy, and saying, well, wait a minute, we now can find out where that's located in the brain ish, even though there's not a functional atlas. At the same time, we can appreciate that these pathways are mediated or modulated by certain transmitters, modulators, and so on. And integrating that, again, I think of, but as a real example or tangible one, what Nancy McWilliams speaks to, in that panic grief system being very different, the anaclitic depression being very different than introjective, and responds to different, an SSRI. And
Mm-hmm.
why is that? Well, now we kind of have these layers of information. I don't mean to say we know for a fact. I'm not trying to say anything controversial. The jury's still out, so to speak. But we do have a better and better roadmap in the year 2025 that we ever have had. So I'm super curious what you think about.
Well, I've been at this over 30 years now, and I think we are understandably seduced by the idea of something concrete that represents our emotional and psychological suffering, that there would be a correlate that we could identify through imaging or through laboratory testing, we're still not there. And I think that a comment I read a few years ago about the genetic testing to match pharmacologic, and I did a talk on this. It's been a couple of years, but I really did a deep dive on that. But the punchline I had read that someone, I think it was in the Carlot letter, said the marketing is ahead of the science.
It's a good
Whether
way to
it's,
put it.
yeah, the Daniel Amen, the brain clinic, that whole operation. Those, I think, when you show a scan, PET scan, let's say, or a SPECT scan of, this is the depressed brain and this is the non-depressed brain. I think that is interesting. It's cause, and it is a map for further study, but there still isn't any clinically actionable neuroscientific finding of any kind that is any better than our own clinical interviewing and history taking in terms of matching up treatments that will work best. But I think when you show those scans, it gives the impression that we can. And that it just isn't the case. This goes back into the 80s where, they do lumbar punctures on, get a spinal tap on people who are depressed versus those who aren't. And there are differences, in some neurotransmitter metabolites, but there are some people who aren't depressed who have those same changes, and some people who don't have them. And I think the leap we tend to make, which is not accurate, which isn't scientific, is to assign causality to those differences. If you see the depressed brain, or you measure the serotonin transmission, if we get there, we only have indirect ways to measure that. The conclusion people are drawn to is to say, oh, that chemical change is what caused this problem, when it could very well be the reverse.
Reverse causality,
It
right?
could be that, my dog died, and that's why there's been a change in my serotonin. So it's the leap of causality, from correlation to causality, that we're all drawn to. And of course, we want something concrete to explain. But when critics of psychiatry say, well, psychiatry doesn't have any biomarkers, it's like, that's what psychiatry is. It's problems that don't have biomarkers. If it had a biomarker, it wouldn't be a psychiatric problem. And, 100 years ago, neurosyphilis was a psychiatric problem until they discovered that it's an infection. And same thing with Alzheimer's disease. We think readily of Alzheimer's disease as a disease of the brain and those plaques that were discovered. But prior to that technology, there were crude autopsies done on people with dementia, but for the big psychiatric disorders, when I say big, I mean the depression, bipolar disorder, schizophrenia, OCD. It's true, we don't have biomarkers for them because they're not a singular illness, first of all, and every version of it is unique. Now, there may be biomarkers eventually, but kind of like the genetics of bipolar disorder, in a textbook I read during residency, the observation was, well, even if they find the genetics of bipolar disorder, that still won't explain why someone gets manic at the holidays, or, when their child's getting married, or that the role of the psychosocial dynamics still is manifest, even if they do nail down the genes. So that's what keeps it interesting to me.
There really seems to be, as our colleagues, I think of Oase, speaks to when he was on David Puter's recently, and speaking to how depression is heterogeneous, and that's just not integrated into the culture at all. It's spoken to like there's one, it's univariate in its causality, and spoken to like it's a bottom up, like you're saying. There's this genetic or epigenetic or hormonal or neurotransmission or modulation. And I think that's a great phrase. I haven't heard that one before, of marketing's ahead of the medicine, and so much of it. I mean, the chemical imbalance thing, as I don't know if we'll have time to talk to all of it today, but still pervades the culture. Patients still say it in 2025, doctors still say it in 2025. And there's still this pretty erroneous, again, not to get too spicy,
Mm-hmm.
I'm just trying to get this thing off the ground, belief that that's the thing, that there's an imbalance of, especially serotonin,
Mm-hmm.
like it's been memeified,
Mm-hmm.
if that's a word.
Yeah.
And it's very much part of the culture. There's mugs and pillows and all sorts of kind of
Yeah.
paraphernalia that's like, I need my serotonin, and then it's just a cup of coffee or whatever, or I need my hit of serotonin or dopamine. I'm just getting a dopamine hit. And people have
Mm-hmm.
co-opted, bastardized, what have you,
Yes.
diluted these very meaningful things. I'm not a psychiatrist, but in the world of my continued education in neuropsychoanalysis, which is a big fancy portmanteau, but it's just to say that it's fascinating, like you said, to look at how seeking salience that's mediated by dopamine, how it plays a role in our behavior. We don't know if you're up or down relative to the average of a normal distribution curve, how dopamine affects somebody or not. Is that person going to be on a stimulant, an Adderall or whatever, or not? I don't know. And I don't know how somebody like you, of course, addresses that outside of all these integrative or pluralistic correlates. And nowadays, we're so seduced by the charismatic megafauna. It makes me think of like the leader who says, we have the neurocorrelates now, and this is the cause, and we can see it on the PET scan, or we could see it on the, like I said to Christian, on the voxel-based morphology, and we could see it on the CAT scan, and we can see it on how much oxygen is being metabolized. But then you talk to the person very simply, and they're not addressing the hat that's constricting the blood flow to their head, and they have a fucking headache. And it's this absence of humility that always comes back to, of like, this is really hard stuff. The brain is alive. It's dynamic connectome. It's not static. And these transmitters are not the only thing going on in the brain. There's so many different types of cells and so many different types of cell communication. And it's not to say that the jury will never come back, I think, but there needs to be a certain amount of, back to what we're saying, care, humility, tolerance for this is really complicated, and each person is as complex as they are complicated. And that's something important to valorize, validate, celebrate.
Yeah. Well, yeah, the chemical imbalance terminology will, just because it's so much a part of the culture and the language of how we talk about things. I mean, I think there is a kernel of truth in that, in conceptualizing what's wrong that way. The problem is to, like mentioned earlier, leap from that correlation to a causality. And it's also a problem to reduce it down only to that. So, I mean, I'm not going to do the headache one again, but I'll use this analogy.
We're running out of material already. We've only been talking for 40 minutes.
Oh, well, I'll never run out of material. This one I like because I use it. It's effective. I'll say to a person sitting here, if a fire alarm went off in the building right now, there would be a dramatic change in what we are feeling and thinking. We'd probably get up, we'd run outside. And then we could get back together, or someone might ask you tomorrow, what happened here in that building at 3:48 on Tuesday? You could say, well, I had a chemical imbalance. And there would be a truth in that, because if that fire alarm went off, there'd be an instant adrenaline release, and all kinds of the chemicals would be running wild, a cortisol burst, etc. But if you didn't mention the fire alarm, if all you said was, I had a chemical imbalance, you'd be missing the major, most important thing that had happened. And I think that's where the chemical imbalance trope is just not a very useful one. But I also don't agree that the notion that, serotonin, whether you want to call it balance or transmission, has nothing to do with conditions like anxiety and depression. And I think that paper that came out from the folks in Great Britain gave that impression. They said we found no evidence, but what everyone took them to be saying was there is no evidence, and that's not accurate. There's plenty of evidence of the role of serotonin and other neurotransmitters in mood regulation, but the criticism of reducing it down to that and then implying causality, that is an error for sure.
It's there's a little irony, right? That our own perceptive biases that are skewed by unconscious drives, having an axe to grind, having a dog in the fight, are polluting our sort of scientific literacy in these studies. I'm familiar with the paper you're citing, and many more. Forget about the replication crisis in psychology or psychological studies itself, but even in psychiatry, where, like you said, we think they're biomarkers or want to believe, or we want it to be more tangible and neurological or neurophysiological. And then we debate all the times to this very day. Like you're saying, we could have the same paper. And this study's been done in psychology. I'm sure you're familiar, multiple times. And the interpretations of, or once you get to the conclusion of the same data, and people have different results. This has been proven over and over again. And so again, we have to be so careful not to throw the baby out with the bathwater and say it's all gobbledygook and nobody knows what the fuck they're talking about and all this stuff. At the same time, we can't be so dogmatic and orthodox and say that we know exactly what's going on. And yet I feel like everybody who's trying to be moderate or decent or caring again kind of gets lost in that, like you said, the noise, because we're not the ones really screaming. I don't know how to say it. We're not the ones making the loudest noises. We're not the ones. Sometimes I feel like it's the fringe. And again, I don't know if this is correct. I don't mean to sound like I know, but sometimes it feels like the fringe people on either side, if there are two sides, are the ones who get the most, I don't know what the word is, attention or traction.
Well, engagement is the word.
Thank you.
In the social, and that's been well proven that misinformation gets more engagement, outrage gets more engagement.
Yes, yeah. That's why I got to start screaming at you by the end of this podcast, so people actually watch it.
that will definitely get you some views and some forwards.
But yeah, the loss of, I don't know, good faith conversation, moderation, tolerance, balance, no pun intended. It's really something how disincentivized it's become.
Yeah,
No matter the content that people are speaking to, but especially in this realm of psychiatry. Very briefly, I think of, the Surgeon General's warning as a very tangible example when it came to ethanol or alcohol and drinking, and the J curve drama. And the long and short of that was reverse causation. But we knew that 40 years ago, but because of marketing being, I really like that phrase, so thank you, ahead of the medicine or the science, we denied it. We said, oh, the people who drink the least amount or have more health problems. But it was reverse causality. It was because they couldn't drink in the fucking first place because they were liver failure, or some hepatic function was off the charts, or they had issues with their kidneys or other physical ailments. So it was the people who drank a little bit because they were still healthy that were showing that they were healthy. Meanwhile, it was because, I don't have to repeat it, but because of reverse causation. And and now we're acknowledging that the culture's shifting a little. There's more non-alcoholic beverages than ever and all this type of stuff. We're recognizing that it is a carcinogen. Again, this is a hot take, I guess, if people are going to get mad at me, but I am proud of us in a sense that, like, at least we're being tolerant of some scientific literacy in that case.
yeah. Well, I'm currently, I would like to say rereading, but I'm not rereading it. I'm reading for the first time Carl Sagan's Cosmos, the book. I had seen the series
Sure.
and rewatched it, and I know they did a reboot with Neil deGrasse Tyson.
Yes.
And I had read his The Demon Haunted World, the Carl Sagan's book, how science, a candle in the dark. But reading Cosmos, which was published in 1980, just about these very things, about scientific literacy and the ability to discover things through curiosity. But increasingly, that author of *Sapiens*, Yuval Noah Harari, so his more recent book, *Nexus*, and which is also a fascinating read. He's talking about information, and this was a helpful distinction. He made the difference between information and truth. And we live in a world where information is now infinite functionally in terms of access to information, but that truth is a subset of that. And as the total amount of information grows and grows, then truth becomes rarer in a sense that it's
A smaller
a
proportion.
smaller fraction of the
Right.
total. So the ability to discern truth, especially when the sources of information thrive on disinformation and on outrage, and to draw or to foster engagement, that's a threatening prospect if we want to preserve scientific literacy and again maintain our authenticity as humans.
I think about, before we wrap up today, I think about Sagan, maybe him and Feynman are like the ultimate heroes for me in terms of science communicators. To have that charm, to have that ability to engage and still be so prolific in your capacity to communicate intelligibly about incredibly highfalutin esoteric stuff. And they were so original. And that's such a lost art because it's not, again, this is a bit of an aside or a tangent, but it seems rarer that someone would rather be engaged based on our own psychological proclivities or our understanding of what gives rise to people's psychology and landscape or topography. I'd rather watch, a series of, a YouTube highlight clip of people falling down the stairs drunk or into pools than I'm going to listen to Sagan talk about, pale blue dot. But now is like, it could be a better time. It could be a more, prescribed medicine, so to speak, for us to be tolerant of and engaged with minds like that. And it is, to end on a little bit of a sad, it's a shame. I hope that we can still, though, continue in their wake, they were doing.
Well, I think that's how I perceive what you're doing here.
Well, that's very kind.
Well, no, it is. It is. If nothing else, you're having real conversations.
Yes. Yes. I could be as dumb as rocks. I could be annoying as hell, but I am authentic. I've been in 9 years of analysis, and I like speaking to the people we've been speaking to, or our colleagues that we've gotten to know. So I do appreciate that. I'm trying.
Yeah, absolutely. Yeah.
Well, thank you.
Happy
Thank
to be
you
a part
so
of it.
much. Thank you. It really means a lot. And again, if it's okay with you, I'd love to have you again to continue down the science rabbit hole. I think there's a lot of people that would be curious to hear from you about more of the in-depth, neuro pharmacology stuff and how it does fit in, and still holding on to it lightly, modestly, and carefully, because these, like you said, the medications are physical or physiological, and that's a fascinating thing, how that's mapped onto or undergirding somebody's psychology.
Yeah. Well, I'd be happy to be back. Just let me know. And in the meantime, I will be putting some writing out in public on my Substack is called Too Simple to Be Helpful.
Awesome.
So I'll be, people can look for me there.
This
too.
is the first, Doug, this is my first plug. That's how I know I'm getting somewhere. He's plugging his Substack. I'm honored. Right. Substack stand. All right.
Yeah.
It was a pleasure.
Yeah, my pleasure, Max.
Okay, thank you so much. Yes.